Perfect. Thank you so much. So, yes, it's a real pleasure and a real honor to be invited to talk with you today about plan quality review. It is really something that is a fundamental part of my work as a physicist. And it's also really been a pleasure to work with this group of people, the Working Group for Treatment Planning in the AAPM. I've learned a lot from them, and I'm hoping that, what we've learned as we've been putting this talk together will be helpful to all of you. And special thanks to Lindsay, who really has been leading this whole initiative, from start to finish. So it's so exciting to see it finally come together. Now, Lindsay just showed you the schedule for the whole rest of the series. I just wanted to point out that today we're going to cover a lot of material, but the idea of today is we're going to introduce you to many of the aspects of how to check for plan quality in the course of your plan checking. But, the expectation at the end of this is you've gotten a nice introduction, but you will see the same material repeated week after week from different perspectives and from different people. And the hope is that by the end of the lecture series, you will feel, very comfortable with how to go through these plan quality reviews. So if it's too much material today or too fast, don't worry, it's gonna be reinforced as time goes on. There's also a lot of text-based slides in this presentation. I'm going to try to move through those quickly and focus more on examples so that, that can drive it home and you can refer to the text later on. Now, practically all of our lectures are going to follow the same pattern, as you can see on the screen here. We're going to go through aspects of the treatment planning process from patient assessment through simulation through treatment planning. This is kind of the consensus workflow of how to do a plan check and a plan quality review from our working group. I don't think it's important or necessarily, you don't have to follow this process when you're doing your own plan quality review, but I do think that it is very important to form a process that works for you, because in the course of doing one of these reviews, you're surely going to get interrupted, or you're going to find a problem, or a million other things are going to come up. And if you have a workflow that you use all the time, you will be able to kind of figure out where you stopped and pick up again without having to start from scratch or being afraid that you missed something. So I do recommend, as you practice and as you learn, coming up with a workflow that does work for you. So the first thing we're going to talk about today is patient assessment, and that's the first step that I use when I do a patient-specific plan quality review. It's probably also, what our group is recommending, which is you want to get to know the patient. You want to know how the patient got to this point. You want to know what the physician intends on doing with the patient, because with all that information, then when you're evaluating the plan, you can have a better understanding of whether this particular plan is trying to achieve that goal safely and effectively. So there's three components of the plan quality review, and just stepping back throughout the whole talk, the way that the slides are organized is that, the main topic we're talking about is up here, and then there'll be a list of checks that we would recommend in that kind of area. And then the white box is going to be specific guidelines for each individual check. So you can see here the first one is MD, intent and prescription. And you want to review the physician's consultation note, and you just want to see what kind of cancer does this patient have, where is the disease, paying special attention to things like laterality, or if you're treating a vertebral body, to make sure that they're identifying which vertebral bodies want to get treated so you can verify those are the ones that actually are getting treated. If it's in the brain, same thing, different parts of the brain. You want to then read the physician's prescription. And I think a theme throughout my talk today about plan quality review is that you really, through each step of the process, need to stop and you need to think to yourself, is what I'm seeing here reasonable? Is it typical? Is it in line with what I've seen before for other patients of the same type? Because if something doesn't seem reasonable or it doesn't seem normal, it really, is essential that you stop and you ask questions. And hopefully, where you work, you have a culture where anybody feels comfortable and empowered to ask questions and to come to a better understanding, where everybody's working in the same direction, which is just to get this patient treated safely and effectively. So, hopefully those types of questions aren't looked at as interfering, but more in the spirit of trying to learn and make sure that everything's safe. The second check here is, special considerations. So when you're reading through the patient's history or the physician's consultation note, you want to pay special attention to things that are really going to affect the way that this plan is created or how the patient would be treated. So for example, does a patient have a pacemaker? Is there some hardware implanted in the patient, near where the treatment's going to be? Will the patient need respiratory motion management? Would we have to use bolus or flash for this case? Maybe the target is close to the skin. So we're going to talk about all of these things as we go through the lecture, but at this point, you're just trying to highlight for yourself, okay, I see this is coming. I want to make sure that's something I pay attention to as I get deeper into the plan check. And finally, previous radiation. So previous radiation is, very important to take note of. And if the patient is noted to have had previous radiation, you really need to ask yourself, where did that radiation happen in their body? How long ago did it happen? What dose did they receive? Because all the answers to those questions will have a major impact on the current plan, especially if the treatments are abutting or overlapping. And the dose to retreated organs at risk may be tricky because it probably depends on how much dose before, how long ago it was, what the physician's comfort level, what the intention of treatment today is. But again, over time, as you build experience, you want to be able to ask yourself, is what I'm seeing reasonable? Is it, safe? Would it be okay? So on the screen is just an example from my institution for spinal cord retreatment doses for SBRT. And I wouldn't just take these numbers and, just use them in your own clinic. They're just here as a demonstration that, for many, many different previous radiation situations, we have some guidelines for different current situations. The thing I want to highlight the most is that there are some numbers that once you get above them, something that's, maybe not reasonable, we actually have a mechanism where we would ask the physician to get peer review from another physician. So not saying that there never would be allowed to treat to that very high retreatment dose to organs at risk, but that if they chose to do it, we have a mechanism where there's a conversation and a review and a consensus decision there, okay? And that already brings us to our first Zoom poll for the day. And the question is, which of the following listed below summarizes the main goal of the patient assessment phase of a plan review? And I think we'll let you read the answer choices and we'll give you a minute or so to, to select your choice. And maybe Lindsay, if you can just let me know when it's time to move on. Lindsay, you think we're okay? I'm not sure whether we lost Lindsay. If she fell off the call. Okay, she might have fallen off the call. So I'll just continue on and we'll see. Yeah, the poll wasn't launched? Well, let's move on and then we'll see if we can find Lindsay again. She might have fallen off the call one way or another.
Sorry, my
Okay.
power went out. Yeah.
These things happen.
Oh
I think
no.
I'll just continue through.
Okay.
I don't think the poll was launched. I didn't see it here, but just because time,
Yeah, sounds good.
some
I'm
people
so
were
sorry.
voting in the poll. No problem. So,
I'm sorry, Sean. Can you just make me
oh,
co-host? Because once you drop
I
off,
see. Yep,
yeah,
yep.
thank you.
All right.
Sorry, everyone.
Actually, I don't know. Oh, I am the host. Okay. Yep. Make co-host.
Thanks so much, Sean.
Good. Okay, no problem. Welcome back. So, which of the following summarizes the main goal of the patient assessment phase of a plan review? It's to become familiar with the clinical situation and identify any special scenarios that need to be considered during chart review. Right. So again, you want to walk into kind of a check of the technical parameters and the quality and the dose distribution. Before you walk into that, you want to already have a familiarity with this patient's situation and special situations like we mentioned to be considered. The other items, I see some people in the chat said all of them. The other items definitely are true, but we're just talking about this phase before you walk into checking those other items. Okay, let's see. Okay, so after you have an understanding of the patient's history, now you want to walk into their simulation documentation. And the simulation is the foundation for all the patient's treatments going forward. So it really is essential to review what's come from the sim. And again, there's a whole list of checks on the left that we are going to undergo. And the first one is patient setup. So when you look at the way that the patient was simulated and the way that, their body was aligned in their immobilization device, again, you want to ask yourself, does this make sense? Does it make sense for the way that I'm going to have to, design my beams? Does it make sense for, let's say, how much setup accuracy and how much mobilization was used for their patient? And the amount of, mobilization probably depends on your treatment technique. So if you're going to treat maybe simple APPA with parallel opposed beams, maybe, you want to focus a little bit more on patient comfort and less on stringent immobilization. And if you're treating with SBRT, you probably need to have the most stringent immobilization you have. So you're, again, just walking into it and try to look at it from the perspective of, is this what I would normally see for this type of case? And is this reasonable? And here's an example of a patient who was insufficiently immobilized. This was kind of a tricky case where the patient was simulated for a treatment to the left lung, but also to the nearby spine, C7 through T4. And you can see here the patient was immobilized in an immobilization device that's very typical for lung treatment, but not very typical for kind of a neck treatment. And what was found on the first treatment was, the simulated chin position was here, but their head just naturally dipped down on the treatment day, and it actually dipped right into the treatment fields. So we're going to talk about this a little bit later too, but this is an example of, external anatomy that's very mobile, and you want to keep an eye on making sure that's properly immobilized. So there's a couple of things that you could do in this situation. One is you could just maybe use a chin strap to convince him to keep his head in the right position. Or if you've decided that maybe even you're still nervous that the chin strap would give too much wiggle room and you're treating too close to the spine here, you may need to go back and re-simulate the patient with a different immobilization device, maybe a mask. So, when we say to look at these images or the simulation to see if things are reasonable, this is what we mean. Okay, I'm treating here. Oh, maybe this was not done in a way that's, robust enough. Now, the next thing is to look at the quality of the images coming from your CT simulator. And I have examples for all three of these bullet points, so I'm just going to skip right to those. And the first is CT scan artifacts. So if you have implanted metal in a patient, you very likely are going to get artifacts from that metal, streak artifacts from the CT reconstruction. And you can see that that's problematic for two reasons, all this white and black. One is it would affect your dose calculation because it's not reflecting the proper CT numbers in the patient. And the other is that it's blocking anatomy. So for example, if you wanted to, contour, the seminal vesicles or whatever is right here, you can't see them to contour them. So if you see an image like this during, when you're reviewing your plan, there's a couple of options. One is that some manufacturers, CT manufacturers, have algorithms in their software that has metal artifact reduction. So if that's the case where you work, you may be able to go back and reconstruct the CT from the raw data using that algorithm. And you can see that's what this has done here. And you can see there's still some streaks, but you really recover a lot of that anatomy. And this scan would probably definitely be good enough to do a dose calculation on. Now, if you don't have that tool in your toolbox, one thing that we've done before as well is just change the CT number of these black and white streaks to something more like water. That would make your dose calculation something much closer to reality. Of course, it doesn't solve the problem of, the underlying anatomy. So, you would have to delineate something in here, using some other type of scan. But that is your other option. Now, here's an example of a patient where the scan was done, but didn't scan sufficiently far inferiorly. So what you see here in blue is the PTV, or the target for the patient, and you can see the scan stopped right after the target ended. So that's problematic because from the perspective of the treatment planning system, this nothingness down here is going to be interpreted as air. So you're going to get an insufficient estimation of the scatter dose coming from this part of the patient into your target here. So that, you're going to get an incorrect dose calculation. So there's a couple of things that you can do if this happens, which happens to us a number of times a year. The first is you have to check and make sure your whole target is scanned. So of course, if your target is actually cut off, you most likely have to resimulate the patient. Also, if you have, nearby, like organs that respond as parallel organs, let's say kidneys or lung or liver, or some organ that you need to have the entire organ contoured in order to get an accurate DVH and evaluate the important dose metrics for that organ, you probably also have to rescan the patient. But if that's not the case, like in this example here, what you can do is you can actually extend your CT lower, so kind of copy the bottom slice and change its number to something, more inferior. And you get this smeared out image, but the image is probably sufficient to give you a reasonable estimate of the amount of scatter dose that's coming from down here into your target. Okay, and so that was breaking up the not scanning the patient enough soup and inf, but you could also clip the patient, in an axial view, either laterally or ant and post. And in this example, what happened was the patient was a head and neck case, and so they used a small field of view in the scan so they can better visualize all the lymph nodes in the neck, but the target came lower than that. So you can see more inferiorly because the field of view was small, they kind of clipped the two edges of the shoulders here. Now you have a couple of options here if you see that. One is if you still have the raw data available on your CT scanner, you can probably just reconstruct the scan with a larger field of view and get that back. If you don't have the raw data anymore, you do have a few options. One, especially for a target like this, maybe you can probably just get away with having your fields not enter through this part of the body. It would kind of be an unusual beam for this target anyway, because the path length is large. So you may be able to just avoid that area in your beams. Just be careful about where it's clipped. The second is maybe if it's just a small area that you can kind of estimate and it's of uniform tissue, you may be able to extend your outer and draw that in there. Although I have to admit, we used to do this a lot with our old planning system, which was developed in-house. I'm not sure about the abilities of commercial planning systems to do this, but if that may be an option. But of course, if you're missing vital information, you again may have no choice but to rescan the patient. And now talking about variable anatomy. So we already talked about the external anatomy, the chin, could also be the shoulders. But you also have to worry about internal anatomy because it's important to remember that when you take a CT scan, that CT scan is just a snapshot of the patient in time. So you try to prepare the patient so that that snapshot is consistent with, kind of how the patient normally is. But, sometimes it's not the case. Or definitely there are certain organs that, no matter what you do, we all know the bladder, for example, it fills and empties as the day, goes on. So here we have an example of a simulation scan where the bladder was as drawn. And then you can see on the first treatment day, the bladder was not quite as full. It looks like it ended around here. And the bowel has dropped into the field. So when you're reviewing the simulation scan and you're reviewing the treatment plan, you really want to think to yourself, these things are near organs that could be changing, stomach, bowel, bladder, rectum, and you should think to yourself, if this organ changes shape, would my plan still be robust? In other words, would my plan still, um, give the dose that's necessary to the target, and would it still protect the organs at risk? Would it still be safe and would it still be effective? So that's something to pay attention to when you're looking at the CT images.
Hey, Sean. We had some questions in the chat, if it's okay. The really interesting showing how you can add additional slices if some are missing on the scan. One participant is asking how do you do that?
Yeah, so I think it probably depends. I'm sure it depends on the treatment planning system that you have. I'm most familiar with Eclipse. In Eclipse, you do that. You would copy literally you in the image selection area, you would copy the bottom slice, and then you can reassign the Z of that slice, the slice number to something, let's say if this ended at, -15, you can reassign the number for that slice to -20. And then what you're seeing here is kind of an interpolation between those two.
I see. Okay. And if anyone has Monaco TPS and knows how to do that in Monaco, feel free to type in the chat. Otherwise, we can look and see if anyone from our educator team knows how to do it in Monaco.
Great.
There's another question from Mohammed from Sudan. Hi, Mohammed. Great to see you. It says, if my CT system doesn't have a MAR function and my TPS tends to produce hotspots near high density materials, would the manual density correction, while some, what would that solve the problem in planning, or would it be an actual representation for the patient?
Yeah, so if you have metal, if you have, if you're working with a CT image that looks like this, which, we have many times as well, I think you would want to rewrite the CT number here closer to water because that's more, at least a little bit closer than what you're seeing here. But then you have to be careful with your beam arrangement. So, you probably wouldn't feel comfortable entering through this high Z material. You would need to try, if the target was in between these two, you would really need to focus on beams that are, sneaking around them as much as possible because, this is poorly defined here. And I think that probably wouldn't be handled well by your planning system right at these edges. So I think if you change a CT number and you try to avoid entering through the highest density area here, that's still hard to really define well, then you would be okay. If you're really calculating right at the edges, I think you would have to communicate with the physician and everybody else evaluating the plan that there is a greater level of uncertainty in that area. I hope that
I
helps
see.
answer the question.
Yeah,
May,
so
may,
one of the reasons that we avoid doing beams through metal prostheses isn't necessarily because the dose can't get to the other side, but just whatever you calculate, there's going to be a lot of uncertainty with that. So it's better to
Right.
be certain about a plan that has maybe an alternative geometry.
Hmm.
may I share my experience with this situation?
But what was that, Ahmed?
May I share this my experience in this situation?
Yes, sure.
I'm from Egypt, Ahmed Ramadan from Egypt. My experience in this situation that I can delineate the prosthesis or the exit body in the patient, delineate it as a force, as a target, as a structure, and give it a forced electron density, and
Mhm.
the black image or something that related to soft tissue also delineate it and give it a forced electron density as 1, like water. Okay,
Mhm.
then I contact with the surgeon who bought these prostheses to know its material and add it in Monaco as a forced electron density and concept these calculations in my calculations concept the prosthesis the black spots in my calculations. Am I right or not?
That sound that sounds like a correct process to me. Yeah. If I was, you broke up a little bit during, what you were saying, but yeah.
Yeah, and that sounds right to me from what I've heard too. Our physicists will do the same thing. Sometimes they will ask me as the doctor, "Hey, do you know what material was used here?" Usually I don't know, so I have to do the same thing, contact the surgeon. So I think going straight to the surgeon is great.
Yeah. And that's very important when you're entering through the metal, when at all possible, just because of the uncertainties, even if you know the electron density of the actual metal, when at all possible, it's still best to avoid entry through the metal. But there are instances where you have to enter through the metal, and then that would be a situation where you would want to make sure that you have the
Correct dose.
Yeah.
Yeah.
Yeah, I mean, a time that we
Sometimes the
enter
prosthesis or the dental prosthesis in the target that we treat. So we have to know what dose does it attenuate, or what dose does it pass or not pass.
Right, I was going to say the same thing. So sometimes I've had cases where you actually have disease right around this area, and then you have no choice but to treat it. So in that case, yeah, you would want to know the material, update
Yeah.
the number. We were going to talk about it a little bit later, but also you need to then make sure that your CT to density curve is
So
encompassing that material as well. But even then, and even with better dose calcs like Acuros, which is the Boltzmann solver, or EMC, we still let our physicians know that there is, a little bit of, a little bit more uncertainty in that than what we would normally see.
thank you.
Okay.
Sorry for interruption.
Oh, no problem. Thank you. You think it's okay for me to continue?
Yeah.
Okay.
I think so.
All righty. Let's see, where were we here? Right, that's exactly where we were. So perfect. So if you do have high Z materials, so when if you're viewing the scan, you're looking for two types of high Z materials in the scan. One is things that were there for the sim, but may not be there for the treatment. So that would be something like IV or oral contrast, because that you may want to erase from the scan, depending on how much contrast there is, how close it is to your target, and things like that. And of course, as we were just talking about, things that are implanted in the patient, so they're there both for the simulation and the treatment. And there we basically just had that discussion. You want to identify what they are. If you know what material they are, you can assign that material. You probably still want to avoid them unless you have to treat through them. But if you are traversing them, you would want to make sure that they're covered in your CT to density table. Okay. All right, let's see here. Okay. And now another implanted device may be a pacemaker or defibrillator. For all of these types of devices, I already have an idea from reading the physician's consultation notes what we're expecting to find in the body, but it is always a good idea to scroll through the scan and look for anything. So, I'd have to say that it's happened before where there just wasn't noted. Maybe there's a pacemaker, but you have a thorax scan and there it is. So obviously, if you see it on the scan, you want to deal with it as well. And there's very nice if you have one, there's certain things you need to do to manage a pacemaker or defibrillator. But there's very nice guidance from AAPM Task Group number 203. You should combine that guidance with your own institutional guidelines. And here's some general recommendations we have for you. One is you don't want to enter or exit through the pacemaker because the dose constraints for the pacemaker are quite low. And in addition to that, if you're entering, if you're avoiding it, you want to avoid that pacemaker plus some margin, just like we add margin for PTVs and maybe even organs at risk. We understand this setup uncertainty, so you don't want to cut it too close. You want to add some margin if possible. Neutrons are especially damaging to the electronics. So you want to use energies that are non-neutron producing. So most of the time 6x or anything less than 10x. You need to follow the manufacturer's recommendations for cumulative dose to the pacemaker. So again, if the patient's had multiple treatments, the pacemaker is not like, body tissue. There's no healing happening. So you need to pay attention to the cumulative dose to that thing. It's usually between 2 and 5 gray. And you may need to verify the dose, even if you calculate in the planning system, depending on your, the recommendations and what you've come up with internally in your own departments. You may want to verify the pacemaker dose using in vivo dosimetry, and you may also need to do EKG monitoring, interrogation of the pacemaker, other things to mitigate the risk like that. And then finally, once you've reviewed the scan, you have to also remember that the CT scan was taken in CT scanner software, not in your treatment planning system. So there's going to be a transfer of those images from one system to the other. And at any point in the planning process where there's a data transfer, that's always, kind of a point where you have to be very careful because there's a big risk of miscommunication or misunderstanding that could lead to a systematic error in the treatment. So it really is essential that you verify that the correct images were sent over. And if you have multiple images that were taken at the time of your simulation, so for example, a free breathing scan and a DIBH scan or different bladder states, it is essential to make sure that the scan that you're doing your plan on in your treatment planning system is consistent with the scan that you intend on treating on. So in other words, if you intend on treating the patient DIBH, that your plan's done on the DIBH scan, not accidentally on the free breathing scan. And I've seen it a number of times. It's where it has happened that the plan was accidentally done on the same scan, especially for DIBH. If the patient doesn't take very deep breaths, it might not be it might not be apparent right away. So it's something you need to check for. And also, if the patient has had previous treatment, maybe to the same area or maybe not too long ago, and you were maybe doing some registrations or you were bringing those scans in too, you want to make sure that you're planning on the current scan too. So really being careful about the data transfer and that you're really planning on the scan that you're trying to use as representative of the treatment situation is essential. Now, motion management, respiratory motion management is always a big topic. And when you're looking at this patient, you should think to yourself, does this patient need respiratory motion management? Is this a site where we would typically use it? Is it reasonable to use it? Does it make sense for this situation? And importantly, if you've decided to use it, are you actually using it? In other words, is all the information that you need in order to deliver a respiratory motion managed treatment, let's say DIBH or gating, is that documented? Are the instructions there? Is the breathing trace there? Is everything there to be passed down to the treatment as well? And if another version of respiratory motion management is taking a 4D CT scan where you're breaking up the scan, you have a scan that is representative of all of the phases in the breathing cycle. It's important to review that 4D scan as well as composite images that are created from that scan. So the MIP is called the MIP is the maximum intensity projection. So that is, you take each of those individual breathing phase scans and you create a new CT that has the maximum value in that voxel throughout any of those scans. The average intensity is similar, but you're taking the average voxel value as well as the individual phases. And here's an example of a problematic 4D CT. This was a patient who is supposed to be treated to liver SBRT and had 2 implanted fiducials. But you can see that after the scan was reconstructed, you can see it appears that the patient has 3 fiducial scans. And you can also tell, by the dome of the liver or the diaphragm here that something about the 4D reconstruction didn't go well. So this patient had to be resimulated, and the resimulation resulted in a scan that was more representative of what we would expect. I think, this type of thing could easily happen or does easily happen because, the patients may not be breathing regularly, or I just did a 4D yesterday where, every patient was breathing very regularly, and as soon as the CT scanner turned on, they changed their breathing. So artifacts in these scans are very common. So it is something that you really need to look for to make sure that you don't cause any kind of systematic problems going forward. So that brings us to our second Zoom poll, and I think this time it's gonna go well. We're gonna launch the poll and get some feedback from everybody. So when you're reviewing a treatment plan prior to treatment, what would be your main concern if the edge of the treatment field abuts the edge of the planning scan? So I see the poll has been launched, and we'll give you a minute, and then Lindsay, maybe you just let me know when's a good time to pick up.
Sure. We have some answers coming in. I'll give it a minute or so. And if you can't use the Zoom poll and you're on your phone, feel free to put your answer in the chat. Just still have a good number of answers coming in, so we'll give it just a few more seconds. Okay, I think we're slowing down a bit, so we'll end the poll and share the results. And it looks like 51% of people chose answer number 3. The lack of scatter dose will result in an inaccurate calculated dose distribution.
Fantastic. So like we said before, if the scan ends prematurely, everything that would be underneath that scan, at least in the example we showed, or above it, if it was cut off too far superiorly, would be treated like air. So there's going to be an inaccurate accounting for the scatter at the edge of the field. So I see, a number of people chose number 2 as well. That's similar to number 3. Number 2, so the planning system will calculate the dose. You won't have any errors from the dose calculation, but you're just going to have some inaccuracy at the edge of the field there. Great.
We will take this natural pause for one question that we received. And the question was, are there any recommendations for the choice of slice thickness?
Okay, so we're gonna, yeah, so that is a good question for the simulation time. I think we have it later on in our talk, but this is a good time to talk about it too. It depends on a few things. There's a couple of AAPM metal, what are they, MPPG reports, which do have some information about how to commission your planning system. That's MPPG5. And there's another one for SRS, SBRT, which is MPPG9. And those do have some recommendations about slice thickness. So I think those recommendations are you never really want to have a slice thickness greater. Oh, no, I'm sorry, wrong. That was about grid size. But slice thickness is a similar thing. So slice thickness, usually 3 millimeters, I would say, is probably the largest you'd want through a treatment area for conventional treatments. If you have smaller targets like SRS targets or SBRT targets, a smaller slice thickness would be necessary, probably down to 1 millimeter or whatever the smallest that your CT scanner would give you. I've seen one, and sometimes it's 1.25. Smaller slice thicknesses have a little bit more noise in them than larger slice thicknesses, so it's a little bit of a trade-off. And again, if you have the raw CT data, if you reconstructed your scan at a slice thickness of 3 millimeters, you could go back and reconstruct it at a smaller slice thickness, and we've had that before. A case came through the other day where I think they simulated for 2 sites, and one ended up being SRS or SBRT, and they just went back and reconstructed the scan at a smaller slice thickness. So actually, slice thickness we should add that to our list. It's a good one to check.
Agreed.
Anything else? No? Okay. So treatment planning. So now we've done the preparation work of understanding how the patient got here, the patient history. We know now what the intent of the treatment is from the physician's perspective. We've reviewed everything from the simulation. So now it's an appropriate time to dive into a review of the treatment plan itself. So image registration and contouring are really the bridges between the simulation and the treatment plan. So there may be combinations of image sets acquired, CT scans, MRs, PETs, to help delineate the targets and maybe organs at risk in the scan. So for each registration, you need to verify the accuracy of that registration. Any limitations that are noted at that time have to pay attention to those, and you have to understand what uncertainties are introduced from those limitations. So for example, if you have a head and neck plan that you're going to do and you're registering that to an MR scan, it could be that the MR scan wasn't in the treatment position. So you can register the MR and the CT in one place, maybe, up here in the neck, but it may be less accurate more inferiorly. So, understanding that and making sure that everybody, including the physician who's doing the target definition, understands that, is an important part of the process there. as well as talking with the physician to know where you think the registration should be the most accurate in order to help them with their delineation. And here's an example of a misregistration. This patient was simulated to 2 sites at once, the left anterior rib, as well as T7 through T9 vertebral bodies. And since the left rib is an area that does experience motion, a 4D CT was acquired. Okay. And it was noted at the time of the review of the spine plan that it looked like the target contour, which is yellow, and the cord contour, which is red, was shifted a little bit to the patient's left and anteriorly, which looked a little bit funny to the plan checker. And after some investigation, they found out that these contours were drawn on one of the phases of the 4D CT and then transferred over to the free breathing scan, as opposed to drawn, directly on the free breathing scan. And there must have been some small misregistration between these 2 scans that led to this, propagation of the contours in error. So, just an example that these things, you don't think maybe, the 4D, the patient's usually laying on the couch the whole time, but they can move or they could wiggle a little bit. And this wasn't the area of the scan where they're probably paying a lot of attention to for the 4D. So, it is something to always be careful about with the registrations. So what they had to do is they had to redraw the contours clearly, or maybe they could have dragged them over depending on how your planning system works, but they had to be fixed. Okay, and talking about contours, contouring properly is absolutely essential in the way we do treatment planning these days. And I'm not sure of the experience of everybody in the world, but my experience has always been that the contouring is done by multiple different members of the team. So I work in a center where we have resident physicians, attending physicians. The residents practice by contouring, the attendings check, our dosimetrists do some contouring. I know other parts of the world, radiation therapists do some contouring, and definitely now we've introduced like automated contouring algorithms. So contouring is done by lots of different people, but when you're reviewing the treatment plan, it's an important job of the physicist to review the segmentation because it's critical to the way that the IMRT or VMAT optimization was done. And it's also essential for the plan evaluation. And, I think physicists are not trained necessarily in cross-sectional anatomy, but as you see case after case, I think many organs at risk are, pretty clear for a physicist to evaluate. Targets are definitely, the responsibility of the physician, but I think the physicist can still identify if there's any targets that, again, seem quite unreasonable or are very not similar to previous similar patients. And again, they should feel comfortable asking if something looks a little bit weird, because again, you don't want a situation where failure to ask a question or being in an environment where you're scared to ask a question would result in a patient being mistreated. So again, I really hope that, working as part of a group, you're able to work in an environment where questions are welcome from anybody.
Like a double check after the physician.
I'm sorry?
Like a double check for the physician.
Yeah, I don't think the physicist has, the training to evaluate whether, all the lymph nodes are contoured or things like that. I think that's outside of our purview, but definitely some reasonable, checking to make sure it's not, something that's very far from what you've seen before would fall under our purview.
Yes.
So for contouring, there's lots of checks to do. They're all listed on the left. And the first one is the ITV. We've already talked about respiratory motion management a number of times. The ITV is a contour that's supposed to capture the location of the GTV or the tumor throughout the whole breathing cycle. And here's an example where that ITV was drawn inaccurately. So here's a lung SBRT case, had a 4D CT, but the lung target was drawn based on the average intensity projection, which, like I mentioned before, takes every scan related to one of the phases of the breathing cycle and takes the average of the voxel number throughout those scans. And that resulted in an under contouring of the range of the target. So you can see, if you look at the MIP, you can visibly see that the tumor is here, but the ITV didn't capture the inferior part. And that's because on an average scan, of course, the tumor is spending probably the least amount of time down below because it's at the extreme of the breathing cycle. So it makes sense that it would be missed there. So, just carefully reviewing these things would be important. So here's an example, of course, that, no one's asking the physicist to contour the lung target, but it's very apparent that it's incorrect. So here it had to be recontoured based on the entirety of the breathing cycle. And I know some institutions do use the MIP, and other institutions, like my own, we usually use the individual phases of the 4D CT scan. I think either one is fine. You just want to make sure the ITV captures the motion of the target.
What should the sites that doesn't have 4D CT do in this situation?
If you don't have a 4D CT to capture the whole breathing cycle of the patient.
Especially the SBRT sites.
Yeah. Lindsay, I don't know if you have any feedback. I guess if you...
One option is inhale and exhale end of regular breathing scans.
And
Yeah.
make a combination CT from free breathing.
So you ask the patient to hold their breath at the end of regular expiration and the end of regular inspiration, and you take two separate scans, which can give you an idea of what the motion would be, and then just ensuring that you have good margins.
Yes. Ask the physician to take a good BTV.
Yeah.
That include the free breathing and with breathing.
Yeah, and inhale. Right, because the free breathing scan itself isn't going to be sufficient, because again, you're just capturing the CT at some point in its breathing cycle. You're just capturing that segment of the patient at some random point in their breathing cycle. So, you need to be careful there for a small target.
Yes, especially in SPRT.
Yeah.
And then I would just ask if you do want to ask a question audibly, to just please raise your hand, and then we'll stop at natural pauses.
So, okay, I'm sorry.
So, if a target, so the next thing is target and OAR accuracy. It's important to understand, it's essential that if a target's not drawn, it's not part of your plan. So not only do you need to verify that the contours are drawn accurately and completely, but it's also important, as you're looking at the scan, to ask yourself, does everything I care about, everything and anything that I care about in this scan, has it been included in a contour? So here's an example of a rectum that was not completely contoured. And what you see here is the red outline is the rectum that was contoured. And when they optimize the patient, you can see that the dose is spilling back here posteriorly, which you have to expect because the optimizer is trying to avoid the bladder, is trying to spare the rectum, there's some bowel here, so it's just going to always throw dose wherever it's not being penalized for throwing dose. But you can see that there is anatomically rectum there. So we have a situation where we're giving more dose to the rectum than we would like to, although it's not apparent from the DVH. So the solution here, of course, is to go back and recontour the complete rectum and reoptimize. And you can see after that was done that the isodose lines are pulling away kind of consistently and much nicer, and doing a better job of sparing the whole organ. Now, when it comes to contour quality, I think what I've seen many times before, especially with trainees, is that immediately they go in and they try to look slice by slice and very carefully try to make sure that the edges of the contours are right exactly at the correct boundaries of the organs at risk, for example. That is important, but I also have found personally it's very helpful for me to step back and do a much more global look at the patient, where I turn on, let's say, an AP beam's eye view, and I turn on structures one by one, and I'm just looking in a more global way are these structures, look anatomically to be where they should be? Are they the shape I'm expecting them to be? It helps me see if the laterality is flipped, for example. So you can see here, this is a brain case where you can very quickly see that the brainstem is missing a slice here. If you look at the labels of the eyes, this is an AP, so this is the right of the patient. You can see that the eyes are flipped. And also you can see for this PTV here that somebody accidentally, I have to imagine it was accidentally, clicked another part of the CT scan and left a contour there. So instead of, this is just taking a step back and just trying to take a more global view before you dive in. And then, of course, you also need to look slice by slice. I found it very helpful for me. Now here's a case where this is an unusual case where the patient had a kidney transplant, and the transplanted kidney goes into their pelvis, not up in their abdomen where the kidneys usually are. And this patient was segmented using an AI algorithm. And AI is great at many, many tasks, but one thing it surely lacks is a creative imagination to think that there would all of a sudden be an organ in a part of the body where it's never seen one before. So it contoured this structure as bowel. And, to be fair, actually, on this slice, you could convince me it was bowel. But if you look more globally, you can see it's very much kidney looking. So, if this wasn't identified during the plan quality review, you, of course, would risk overdosing this kidney, which would be very unfortunate because this is the only working kidney that this patient has. And also would be incorrectly documenting the dose to the bowel, right? Because it's being called bowel when it's not really bowel. So the solution here, of course, is to resegment and segment these structures properly and reoptimize the treatment plan. So mislabeled contours, are something you always need to keep an eye out for. Now, when it comes to target margins, a good standardization step is to have institutional standards for target expansions, usually as a function of the treatment site, the immobilization you're using, the treatment technique, and maybe, let's say, on-treatment monitoring, because that will, of course, whatever margin you decide you need for that type of setup should be consistent from physician to physician or patient to patient, because it's not related to the physician or patient, it's related to the setup itself. And B, the standardization will help with your workflow. So you're not always asking, you just know, okay, for this site, we use whatever, a 3mm expansion. And this is definitely an area where we talked about how the physician's job is to contour the targets, but properly evaluating the expansion of the anatomical disease, let's say the GTV or CTV, to a PTV, I would say also does fall under, one of the roles of the physics team. So here's an example of an improper PTV expansion. You can see they contoured these vertebral bodies and have a very small CTV to PTV expansion for this SBRT case. And if you zoom in, you see here that the CTV is outside of the PTV. Now, after investigation, it was found that what happened was somebody drew the CTV quickly, expanded it to a PTV, and then the physician shaved down the PTV to be a little bit tighter. Probably a better thing to do would have been to shave the CTV and reconstruct the PTV, then it would have been more consistent with less questions. But definitely this would be something that you would want to ask questions about. Why is the CTV not covered with my PTV? And then there is, in most planning systems that I'm aware of, a special contour for the body or external, it may be called, that defines where the dose calculation should occur within that contour. So in other words, if it's in that contour, that body contour, yes, you calculate the dose. If it's outside, you're not going to calculate or display any dose. And it really is essential that you understand how your particular treatment planning system handles this, because if you don't understand it and the contours are done in a way that's not correct, you could be introducing, systematic errors to your treatment. And in addition to the body, some treatment planning systems allow you to add other structures for, support structures like, the couch that the patient's going to be laying on, for example. So here's an example of a CT scan, and you can see that this body contour is including the patient's body, of course, but also the immobilization device that they're laying on. You can see this device has a little bit of structure. So you would want to incorporate that, the CT there. At the same time, there's another thing down here that has some structure to it. And you can see we're excluding that from the CT. And that's because it's the couch from the CT scanner itself. So that won't be there for the treatment. So we would want to exclude that from the body. But you can then, in some planning systems, go back and add a model for the CT couch that you're using so that when you have a beam traversing this way, you would not only counting the attenuation through the patient, you would incorporate the attenuation through the immobilization device, as well as the attenuation through the couch that they're laying on. And again, high Z structures are coming up. So I think we've already talked about this, but if you have high Z materials in the patient, let's say when you're looking at the CT scan, you're saying, oh, there's contrast, it's not going to be there for the treatment. I should override the CT number. As you're looking through the contours, another thing you should do is make sure that that CT number was properly overwritten. In other words, if you were writing it down to water, that it was written to water and not accidentally written to air or something like that. Now, when it comes to flash, if you have a target that's close to the skin surface, your treatment planning system, as we just talked about, only is going to be calculating dose up to the surface of the skin. So here, I think I should just dive right into the example. That would probably be visually better. So here we have a patient who's, they have some kind of disease in their shoulder, let's say, in their humeral head. And when you do the PTV expansion, you see it comes outside of their outer contour. But then, like we said, the planning system doesn't calculate the dose. It knows it can't deliver dose basically to the air. So you see it's chopped down here, which is problematic because, of course, if the patient during the treatment is a little bit higher or lower, you may be cutting off the treatment area. Another problem is if you're doing IMRT, some planning systems during the optimization phase may say, oh, I need to cover this, but it's so close to the skin. And it may try to put a lot of intensity through that beam, which would give you maybe intensity peaks, which probably isn't great either. So there's two things to look for. One is intensity peaks, where you're trying to give too much fluence in an area where it won't really translate into dose deposition. And two is, oh, maybe I'm not accounting for the setup uncertainty because I'm coming out of the skin. So Flash deals with the setup uncertainty part. And I know different planning systems, apply Flash or use Flash in different ways. So I'm not going to get into that specifically here, but as you're reviewing the plan, you definitely would want to make sure that appropriate Flash is being used. So now you see if the patient does move a little bit sup-inf, they still would be in the treatment field and you're still feeling confident that your target would be covered. Okay, I think that brings us up to our third Zoom poll. So when reviewing a treatment plan prior to treatment, which of the following should be included in the dose calculation? And then Lindsay will keep an eye, but you can let me know when you think it's a good time to continue.
Okay, the poll has been launched. And I'll just take a moment to mention that there's been a lot of good chatter in the chat and questions about what to do if you don't have the ability to perform a 4D CT for lung SBRT. And I think this is something that we might have to talk about as a group and get back to you on the best recommendation. Just because really it truly is not recommended to do lung SBRT without 4D CT. So, all right, we have about half of the participants have answered. Okay, I think I'll go ahead and end the poll and share the results.
Perfect. Great. So the majority of people said number 4. Oh, the majority of people said number 4. Let's see. Patient anatomy, mobilization devices. So the majority of people said number 4. So it's true, you want the patient anatomy, the immobilization devices, the support structures. But when you're doing your dose calculation, you do not want the CT simulation couch because that was the couch that the scan was acquired on, but not the couch that's going to be used for treatment. You would want to include if you have the model in your planning system, you would want to include your Linac couch, which I think is one of the things we meant by support structures here. Okay. There's some, some newer technologies where maybe you're doing a CT scan on your treatment unit itself for planning, but that's kind of out of what we're talking about today. So you would want to exclude the CT sim couch, and I just want to make sure that we got that clear here. That's what we're saying here. We're going to X that out, and we're not going to include the CT couch. Okay, I don't know if we shared those. There we go. Lindsay, should I continue, or are there any questions?
So there's a comment just saying that normally the CT couch would be like the Linac couch. And so I would just mention that often it's quite different. The CT couches can be quite dense, where many Linac couches have less density. So they're made of carbon fiber or that tennis racket material. So that's why you might have a lot more attenuation through your CT couch if you're including it in your dose calculation than you would if you were including a model of what your Linac couch looks like. So that would be one reason to not include the CT couch in the scan, but include a model of the Linac couch if it's available. If there's no model of the Linac couch available, I'm not sure what you would say, Sean, but I would say probably still remove the CT couch and not include the Linac couch if you don't have that option.
Yeah, I agree. This couch here is one that we always add because you can see it throughout the whole treatment. But we've had other machines that have couches with movable bars in the tennis racket, and in those cases we haven't added the couch model, but the therapists have gone carefully to make sure that those bars are moved out of the way of the entrance of the fields. So that's another thing that you could do there if you're concerned about the transmission through the couch.
And then there is another question about what would be an option for Flash for VMAT and how to overcome that. And that might be a bit of a long discussion, although just going to mute. Although we do have some guidelines we'll be sending as supplementary material for this course that really explains how to create Flash for your patients. And that's something, if you have questions on Flash and the specifics of how to create Flash for your patients, you can reach out to, I'll put something in the chat for the training email, and reach out, and hopefully we can get you some good resources for that.
Perfect. Thank you. Okay, so beam design. We have a list of beam quality checks on the left here. And the first one is the treatment technique that you're using appropriate for this patient? So every single one of us lives in a resource-constrained system. Maybe, the highest technology machines not necessarily available for all patients. I know it's not where I work. Maybe not everybody's trained to use that highest technology. It takes more time and effort for IMRT, IGRT, SRS, and maybe insurance providers or governments or whoever is not willing to pay for the increased complexity. So I really actually would say that simpler is better. If you're going to get the same therapeutic effect with a simpler treatment, it's always recommended to go that way. There's less opportunity for error. You could increase the speed of getting the patient on treatment, and you could actually deliver the treatment faster. So keeping an eye out for which patients should need kind of all the bells and whistles and which patients really would benefit from something without those bells and whistles is something to think about as you're going through the plans. Now, when it comes to beam arrangement, you want to ask yourself, is the number and direction of these beams reasonable? And again, it would be very helpful if you form a department standardization. So for particular body sites that you treat frequently, if you had a standard beam arrangement, it will help you with quality and throughput. And when you're looking at your beams, you want to say, for the anatomy, are the chosen angles the best to avoiding unnecessary dose to the organs at risk? So here's an example of what is supposed to be a simple plan. The physician asked for a plan that was mostly ant and post, and you can see that the plan was created just like that, mostly ant and post, but you can see that the bow was given a lot of dose. So there was a question asked. They went back to the physician. They said, well, why did you want this plan to be so simple? And they said, listen, I just need to get this patient on treatment quickly, and I want them to get through the fraction quickly. They're not in great shape. So, there was a suggestion to say, hey, listen, we can do a single conformal arc, which will also be very fast and quick and easy, but it will spare all that bowel. So it did, and the bowel D2 cc's was reduced by 35%, and the mean bowel dose was reduced by 43%. So I think one of the take-home messages there is that it's important, again, to have these discussions, and it's also important to understand the physicist has the technical expertise and understanding, and if they could understand what the goal of the treatment is, they may be able to suggest something that, a way to find an optimal way to treat that patient, encompassing all of those goals. In terms of beam deliverability, collisions is always something that we have to pay attention to. Here's an example of a prone breast patient on what's called a prone breast board. So the purpose of this is to hang the patient up. So if they have a pendulous breast, it hangs down away from the heart and lungs. It allows you to, treat the breast without treating the heart and lungs too much. But because they're so high above the table, you can easily have a collision with a contralateral beam here and the edge of the couch. So that's one example. Another thing to pay attention to is, again, your scan range, sup-inf, let's say, is always limited. So it could be that you have anatomy of the patient that's outside of your scan that could cause a collision, like an elbow or a head or a knee or something like that. So it really is good practice to do a dry run of all of the gantry angles on the patient before you start treating to make sure there's no unexpected collisions that you weren't able to anticipate. And then about beam robustness. So we already talked about that example of the bladder where we had the bladder changing and the bowel moving in and out of the field, and we were trying to think to ourselves, is my plan still going to be, applicable with that bowel there? Here's another example of external anatomy, like the shoulders. So you can see this patient was simmed in a mask that only holds their head and neck, but does not hold their shoulders, but the contours came down. The target is down here through the superclav area. So we have this situation of variable anatomy. The shoulders could be moving into and out of the field, which would affect the dose to the target and the organs at risk. So there's some things you can do. Again, if you're doing fixed gantry, you maybe, especially for a target like this, could just avoid entering through that variable anatomy. That way, if it moves a little bit, it's not going to affect your plan. That would be robust. If you're doing VMAT, so you're treating, let's say, whole arc around the patient, you could segment with some margin those shoulders. And when you do the optimization, you could tell it not to enter through there. So in effect, it's skipping this area as well. Although maybe the beam could still be treating, up here in the head and neck with away from the shoulders. And then when it comes to beam energy, so I think now lower energy beams, 6x or 10x, are the most common, especially for multiple field techniques like 3D CRT, IMRT, VMAP, because you're coming from a lot of different directions. You're minimizing the hotspots away from the target. 6x or 6MV definitely be recommended in the lung due to the physics, the loss of electronic equilibrium, which gets worse as the beam energy increases. And some dose calculation algorithms, especially more historical ones, really had a difficult time modeling this lateral electronic equilibrium loss. So keeping the lower energy is helpful. Of course, also, if your disease is near the skin, you want to use a lower energy since the buildup region, the width of the buildup region increases as the energy increases. But for simple beam arrangements like APPA, 2 or 3 field beam arrangements, you may want to use a higher energy to account for the patient's size or to minimize hotspots. Now, when it comes to electron beams, the choice of electron beam energy is critical, right? Because electrons stop pretty quickly. So there's some rules of thumb you can use to check if the energy that you're using is reasonable for where the target is. The treatment depth is around the energy in MeV divided by 3, and the range in centimeters is the energy divided by 2. And it's also important to remember that the skin dose increases as the electron energy increases. So once you've looked at the general beam arrangement, you can focus on each of the individual beams parameters. You can look at the collimator angles, the jaw positions, and the MLC position. And for VMAT specifically, there is a general recommendation to avoid collimator angles of 0 degrees. And that's because as the gantry is rotating around the patient, if the leaves are also in the same direction, that effect of the interleaf leakage, the tongue and groove, all that's going to add up on the patient and give you some dose banding in the dose distribution. So I think, again, stepping back as a plan checker, you always want to look at the characteristics of the dose distribution. We'll talk about the dose distribution in a minute. Where's the hot spot? Where are there streaks? Is there banding? And you want to say, what is it about the beams that were chosen or the collimator angles that were chosen or the MLC that resulted in that? And can we reduce it by making some changes there? And I have some example of MLC limits right here. So here's an example of a patient who's getting treated to the scalp, face, and neck. Okay. And they use this collimator angle here, but the the leaves can only travel so far in their leaf motion direction. And in this particular machine, since they're trying to treat the target here and treat the target here, they're not able to block this part of the patient's normal tissue that's far away from the PTV, giving kind of unnecessary dose there. So the solution was to replan this patient with different collimator angles. So you can see they conform much better to the PTV. They block that area of the organs at risk that are far away. There is an increase in the plan complexity, so I don't think you typically want to, use multiple different collimator angles for the same gantry angle. But, in situations where you identify a major problem, it is a potential solution. Then when it comes to dose rate, for non-VMAT treatments, you likely would use the same dose rate for most of your treatments, and that's probably most typically going to be the dose rate you do your output, checks at. Now for VMAT plans, the dose rate is modulated just as the gantry speed is modulated and the leaf motion changes. So you want to review the fields to make sure that if the dose rate's very high or very low, it could be an indication that you need more or fewer treatment fields. And then for IMRT or VMAP plans, you do have to watch out for overly complex delivery patterns. So if your plan is too complex or is stretching your treatment machine to its physical limits, you're going to lack robustness. In other words, your plan might look really nice on paper, but in the patient, when you incorporate all the little uncertainties in the machine and the patient position, it's what you're seeing on that paper is not going to actually be what happens to the patient. So you want to avoid being overly complex. And there's a couple ways to check for that. One is a qualitative way, just looking at the MLC patterns and making sure that you don't have many, many, many tiny openings. And another way you could do is with this thing called the modulation factor. So the modulation factor is you add up the monitor units for each of your treatment fields and you divide by the prescribed dose, okay? And it gives you a number. And what you can do with that number is you could acquire that data for a number of your patients. Let's say all of your prostate patients, they're getting a certain dose, or all of your lung patients getting a certain dose, or all of your brain patients. And you take the good plans that you have, you take plans that if you did IMRT QA, the results were good, and eventually you have kind of a number you would expect for that treatment site. And then going forward, if you have a treatment where that number is, much higher than you expect, that's a hint that maybe you should look more closely at that plan. And here's an example. So here's an SRS case where they did a very nice plan. It has very nice PTV coverage. The grading index, in other words, the dose fall off away from the PTV was nice and tight. But when they looked at the MU factor, they got 3.6. So the sum of the monitor units divided by, let's say, 2400 centigrade was 3.6. That was a little high. And they replanned this case, okay? They got the same target coverage, the same grading index, basically the same plan with 2400 monitor units less. So, it just goes to show you that more monitoring use doesn't always mean that you have a better plan. And actually, you would argue this plan is better because this one is probably less robust to small errors and leaf positions and things like that. So that's one tool that you could potentially use to look at the complexity of the plan. Then if you're using items like wedges or physical blocks or compensators, you need to make sure that those are being properly applied in your planning system and that, the use of those is communicated down to the therapist team so that everything's consistent between the plan and the treatment. And then when it comes to bolus, different treatment planning systems handle bolus maybe differently, but it's a couple of important things to check is the size that I'm using in my plan consistent with the size I'm meant to use and I'm telling the therapist to use on the patient? That's this, I would say, the size and the location, as well as the thickness of that bolus. And then the density. So many planning systems, you would assign the density of the bolus. You want to make sure that's consistent with what's going to be used for the material used for treatment, usually water, but it could differ depending on the material. And in some planning systems, you have to not only draw that bolus on the patient, but you have to attach it to the treatment fields that you actually are going to, you would attach to the treatment fields that when you deliver those treatment fields, the bolus is going to be on the patient. So you need to check for that as well. Okay, our fourth Zoom poll. So when you're reviewing a treatment plan prior to treatment, what is one of your primary concerns when considering the robustness of the beam arrangement? If Lindsay's here, I'll let her launch the poll.
She may have fallen out again. I don't see her.
Oh, okay. Let's see if I can launch the poll then. Jose, thank you. I made you a co-host too, just in case. I got this one here. So the poll should be launched. Are you able to see it? Looks like it. People are starting to vote. Okay, those votes are coming in. All right, maybe just another moment here. Great, we got about 60%, so I'm gonna end the poll and share the results. All right, let's see, what do we have here? So when reviewing a treatment plan, so we had a mix of answers, but the largest number of people answered number one, planned and delivered dose. And that's the correct answer. So a plan that looks nice on paper, but it's not deliverable or not robust, it's not going to do the patient very much good. So you want to treat it with a plan that you have high confidence will be consistent with what your TPS calculation says, because that's what you're basing your decisions off of. Okay. Let's see, when reviewing a treatment plan, primary concerns. So you are, of course, concerned about the dose calculated by the treatment planning system, but I think that part of it, your focus on that part should be happening sooner, earlier in the process, kind of when you're commissioning your treatment planning system. Yeah, okay. So I'm going to stop sharing here. I'm going to close this, and then I'm going to move on here. And I know we're a little bit tight on time, and Lindsay may have dropped off, so I'm going to continue through here just to make sure we get through all the material. I think you guys were warned that this was a little bit of a long one. So optimization. So if your plan, so after you've looked at you have your contours, you have your beams. If you're doing IMRT or VMAT, of course, the optimization process is a very important part of that process. So some things you need to make sure have happened. One is you want to make sure that none of the targets have been accidentally left out. And then for the targets, you want to make sure that the minimum coverage and the maximum dose constraint is reasonable. You need to understand that there is going to be heterogeneity in your target, dose heterogeneity in your target, just because of the size of the target, is close to organs at risk, other things. So your optimization needs to account for that by having enough separation between the minimum and maximum constraints. And if you don't, you may inadequately spare organs at risk, or you may make a plan with too much modulation. And it's similar for the organs at risk. You want to make sure the objectives are set appropriately. And you also want to make sure that the objectives used are related to the sparing that you're looking for. So if you're trying to spare the maximum dose to the spinal cord, it's not very helpful to optimize on the mean dose to the spinal cord, right? it's much simpler to constrain the parts that are related to the dose objectives that you have. And most modern optimizers display the progress of the optimizer as it's working. So if an organ at risk is easily meeting its constraint, it's a good idea to try to reduce the dose to that OAR further, as long as it doesn't hurt the other aspects of the plan, the target coverage or other organ at risk doses. But you don't want to push it unreasonably low, because if you do that, you could hurt the target coverage, you can hurt the other organs at risk, and you again can introduce excessive modulation. You may also see, as you're looking at your treatment plan, as you're looking at the dose distribution, that it's not as you expect. It's not reflecting what the physician wanted in terms of their priorities, and that could be because during the optimization, the priorities set in the optimizer are not consistent with the goals. In other words, if the cord was the most important thing to spare, and you're having trouble sparing the cord, maybe it's because they didn't have a high enough priority in the optimizer. And then, as I mentioned before, when you're doing inverse planning, if a structure is not drawn or it's drawn but not included in the optimizer, it doesn't exist. The dose will likely be pushed there, okay? Because the optimizer is trying to push dose away from everything you've told it about. So here's an example of a head and neck case where you can see here's the larynx and there's target on either side. And when the physician reviewed the plan, they said, this larynx dose is a little high, but I guess it's just because it's too close to these other PTVs. After some more investigation, it was realized actually that the larynx had not been included in the optimization at all. So when we went back and re-optimized this patient, you can see that you got a lot more sparing of the larynx, and the cord dose is basically the same. The target coverage is basically the same, but the larynx dose was decreased from 44 to 30, mean dose was decreased from 44 to 36 gray. So it really is essential that every organ you care about, you do add to the optimization. The other thing to worry about are conflicting objectives. So for example, if you have a prostate PTV and a rectum and they overlap, if you're asking for 100% coverage of the prescription dose of the prostate PTV, and you're demanding that the rectal maximum dose is less than the prescription, you're introducing a non-physical contradiction, a conflict that is just not achievable. And if you do that, the output is going to possibly have inadequate target coverage or inadequate organ at risk sparing, excessive hotspots, dose streaking, high modulation. It's important when a person optimizes to create the optimization in a way that reflects the physical reality of what's actually happening in the patient. You can't ask for impossible things. And there's a bunch of tools also for unspecified normal tissue to make sure that your gradient and your dose fall off is sharp enough. Different planning systems are called different things, but it could be called normal tissue optimization or dose fall off objectives, rings, rinds. And here's an example where they were not used properly. So this patient is being treated to the prostate as well as the lymph nodes above the prostate. And the prostate was going at a high dose per fraction, and at the same time, the lymph nodes are going to a lower dose per fraction. And what happened was they created this ring structure around the prostate and the lymph nodes, but when they constrained the dose to that ring structure, that dose was, related to the high dose per fraction prostate part, not the lower dose per fraction lymph node part. So what you ended up with was all this dose spillage here. So the solution was to create a second ring structure, and now you have one that focuses around the prostate at the higher dose per fraction to make sure the dose is conformal there, and you have another one that's up around the lymph nodes to make the dose conformal there as well. Okay, and it's important to note that this would not be seen on the DVH. It's only from a review of the isodose distribution. Okay, and talking about the isodose distribution, there's also a number of checks there. And the first is verifying that the planned prescription and the planned normalization methods are correct and appropriate. Okay, I'm most familiar with Eclipse, and I can tell you, and showing it on the screen, Eclipse has so many different ways to normalize a plan. There's field normalization, target normalization, plan normalization. It's extremely confusing. Okay, so if you're confused by this slide, you're supposed to be, because it's very confusing. So I recommend having a departmental standard approach for how each plan should be normalized. Okay, that way you save yourself all these decisions and you just always normalize in the same way. And I think the second thing is that when you're looking at the isodose distribution, when you're looking at the coverage of the target using the isodoses, to review that in terms of absolute dose units will help you sidestep all of the questions about what's the relationship between the percent dose and the absolute dose. You just directly look at the absolute dose, and that will stop you from being confused into making a misjudgment of the plan. When it comes to algorithm and grid size, I started to talk about this before, but the question before was about slice thickness. So grid size, you have different options of grid sizes, and when you choose a small grid size, you're going to get more spatial accuracy, but it's going to take longer to do the calculation. For a larger grid size, you can do the calculation faster, but you lose a little bit of that spatial accuracy. So there's a trade-off there. But there are recommendations, like I said before, Medical Physics Practice Guideline 5 deals with commissioning of your algorithms, and 9A deals with SRS SBRT. And you can see they recommend for SRS target 1 millimeter grid size, and maybe you can do larger for larger targets or 3D CRT. I know there's an SRS talk tomorrow, so I'll leave it with them. When it comes to target coverage, you should review the target coverage on each individual slice of the data set, again in absolute dose. And when you're looking for hotspots, you should review both the magnitude and the location. So here's an example of a partial breast case where the high dose PTV, the high dose, the hotspot, was outside of the PTV, which is in yellow. And this was due to the choice of the beam angles or the wedge angles or the beam weighting. And you can see when they adjusted the weighting of those beams, they were able to move the hotspot at least into the PTV and also lower its magnitude. So instead of 109, it went down to 106. And during plan review, we've already kind of talked about, we looked at that high dose line around the lymph nodes of the prostate case, but you want to look also at the medium and low dose fall off. And you want to think, are these, is the dose fall off I'm seeing reasonable? And is it what I've seen before? So here's an example of an SRS case where the patient's getting treated in a single fraction, but the physician asked for something different than usual. They asked for to keep the dose in the PTV as homogeneous as possible. So when the planner created a plan like that, they gave them a nice low hotspot, 106. But the penalty of that is that the 50% isodose line was quite large, right? And you can see the gradient index was 10, and this normal brain tissue getting 12 gray was 9 cc, and that was quite high. So they went back and replanned this case to be more of a traditional type of SRS plan where you accept high heterogeneity through the target by prescribing to kind of a lower isodose line, but that enables you to reduce the dose fall off outside of the PTV. So you can see that the 50% line, which is the edge of this, has decreased in size, actually by a factor of 2, and the amount of brain tissue, the rate getting 12 gray went from 9 to 2.5 cc's. So looking for these types of things, instead of just looking at the coverage of the target, really could have a very high impact on your plan and the quality of the treatment. Again, you want to look at the organs at risk and make sure they're spared as much as possible in the order of clinical priority. So in other words, if your parotids are more important than your submandibular glands, hopefully they're pushing the parotids lower before they push the submandibular glands lower, right? So a high quality plan pushes those organs as low as possible, not just to the number specified by the physician, but to the number that's physically deliverable in a way that won't hurt the target coverage or hurt the organs at risk. Okay, and how do you evaluate this? Well, comparing it against what the physician asked for is not a great way because the physician is asking for kind of the minimum acceptable value. And now you're looking for what's the optimum value. So the best way to do that is look at your dose distribution. You look at the relationship between the PTV and the organs at risk, and you look at the gradient of the isodose lines and see if that gradient's tight enough, or if it could be tightened, or if it could be made a little bit more concave. You want to look at the isodose distribution and see those dose gradients there. And you also have to understand these clinical priorities. So for example, again, if you have a head and neck case and you have a cord and a parotid, it may be that the physician's willing to hurt the PTV coverage for the spinal cord because that's a higher priority constraint. But for the parotids, maybe wants you to increase the parotid dose to make sure the target coverage is high enough. So this is the type of thing that needs to be worked out and communicated and well understood by everybody. Now, when it comes to the dose volume histogram, the dose volume histogram is an excellent tool to give you quantitative information. And if you have a list of goals, let's say, that are coming either from the physician for this patient, or you have departmental standards for this site of disease, or you're doing a protocol, a national or international protocol that has dose constraints, the DVH is great because you can compare what you have against those constraints. But it's always essential to evaluate the DVH in combination with the isodose distribution because the DVH does not have any spatial information about where the dose is. And it also, again, will tell you if you're meeting the goal, but it's really only through looking at the isodose distribution if you see if maybe you could have pushed those structures lower. And then when it comes to radiation, prior radiation, like we talked at the beginning, it has a major impact on your plan. Oops, I'm sorry. Before I get to previous radiation, I read ahead. For DVH metrics, if you would like to establish departmental standard DVH metrics, there are information in the literature or guidance that you can use. So for example, Quantec has been around now for over 10 years. Those are normal tissue values. There's a newer one called HITECH, which is for hypofractionated treatment. And I believe there's one being created now for pediatric patients called Pentec. So that's just one source. There's also, international, protocols that you can look at as well as in-house. And here's an example from us of one of our score sheets where you have for standards. So we have SBRT prostates going 800 times 5. These are the goals of what we normally look for. And then you get color coded. If you're meeting the goals, it's green. If you're higher than the first level goal, but still okay, it's yellow. If it's, the doctor has to specifically sign off, it's orange. Anyway, it's just a way to give you a quick snapshot of how your plan's doing. Again, in combination, you need to look at this with your dose distribution. But this standardization is very helpful because if you treat your patients using the same constraints, you can have a better idea to correlate that with outcomes, less questions asked, you'll be able to do your plans faster, you'll be able to do the consistency of your plans will be more similar. It should help in many different ways. And now with previous radiation. So I can tell you that in my practice, even compared to 5 years ago, the number of treatment sites per patient has increased a lot. The number of retreatments has increased a lot. The number of partially overlating treatments every year just increases and increases. So it's essential to make sure that the current plan is viewed in the context of the patient's radiation history. So we talked at the way beginning that the physician's consultation note is the first place to get information about the previous treatment. If you can get a copy of those previous treatment records, it's essential to do that whenever you possibly can. Okay. I think that we could probably talk for a whole other session or even a whole other course about evaluating previous treatments. There's no time for that today. But today, just to let you know, there is, again, just like Quantec, there's guidance in the literature about how to deal with previous treatment. And this paper is one example. And I think that brings us to our last Zoom poll. I'm not sure if Lindsay's been able to join us again.
I am here, although not a co-host.
I can launch it.
Okay, sorry, Sean.
No problem. I can launch it. So number 5, when assessing if a parallel organ at risk has been spared optimally, what's the most important piece of information to review? We have some results coming in. Looks like we're about a third of the way. Looks like they're slowing down now. So we have a mix of answers, it looks like. I'm just going to share it. I'm going to end it here and share. All right. Okay. So there's a mix of answers here. So when assessing if a parallel organ at risk has been spared optimally, what's the most important piece of information to review? Let's see. So let's see. most of the people, well, there's spread out answers, but the slight majority of the people said DVH metrics. Reviewing DVH metrics is essential. It's very important. But when you review the DVH alone, the best you can do is comparing that against what your clinical goals were. So that's always the first step. You need to meet the clinical goal. But if you're looking to see if you could have gone above and beyond the clinical goal to get that dose even lower without hurting PTV coverage or other organs at risk, you're going to need to combine that DVH with looking at the isodose distribution. Looking at the dose gradient in that area would be the way to help. And another big group of people said the volume of the organ at risk. So the volume of the organ at risk does, of course, for a parallel organ, plays into it here. So the volume of the organ at risk. So again, I think that would be a part of a visual exploration of the dose distribution. So if you're talking about a lung, for example, you would be able to look and see how big is my target relative to the lung, and where's my isodose distribution relative to the volume of the whole lung? And that would help you come to an understanding of if you're sparing enough of the lung or not. But again, I think the volume of the lung plays into this isodose distribution as well. Okay. All right. Again, I think we're a little bit low on time.
Yeah, I think we can keep going. We don't have any, we'll just save 1 or 2 questions for the end, but I think
Perfect.
we're good to.
All right. And we're almost done here anyway. So just very briefly on communication. Your role in the plan quality review and plan check is just one link in a very long chain. You know, there's people before you who gathered information, did the simulation, did the treatment plan. Of course, after you is the treatment delivery. So it's really important that you are properly handing off information to the next group of people. So you want to make sure you finish your checks in a timely manner. You need to communicate with the treatment team about anything that's important for them to know. For example, most of the things on the screen, imaging requirements, number of isocenters, anatomy to look for. And what I think a common practice is here, and definitely in my institution, is for particular situations, SRS, SBRT, matching fields, isocenter shifts, multiple isocenters, we actually have a physicist go to the treatment unit for the first treatment and help make sure that communication is all done properly, answer questions, and also evaluate the setup of the patient to make sure that everything is as we planned. So that's just a way of making sure the communication loop is closed. And then when it comes to incident learning, I can guarantee you that as you're doing these plan checks or plan quality reviews, you're going to find problems. I can also guarantee that unfortunately, you're going to miss problems that exist. They're going to slip past you. Everybody makes mistakes. This is a very high and complex process with many, many, many steps. So mistakes will slip through. So sharing what you discovered in a constructive way that that should anonymize the individuals and instead focuses on the process itself. If you share that information with your colleagues, it really will help them be on the lookout for similar problems and help them catch those problems. Similarly, it will help you in the future catch problems. So one way to do that is by using an incident learning system where you enter information about the event. Again, usually shouldn't be with the names of the individuals, but with maybe their job roles or the clinical situation that happened. And it gets reviewed by a committee of people, like a quality assurance committee, that they can identify root causes that maybe need to be addressed by changes in policies and procedures. They can monitor for recurring issues so that they can bring awareness and erect new safety barriers. They could spread the information in a constructive, forum that everyone can learn from the mistakes. They could focus on having a no blame culture where we're all here to learn and to improve safety. And if you're able to establish that type of environment and use a system like that, you will see the quality of your department output increase. And it's a continuing process. There's not a single department on the planet Earth that could not use improvement. So it's a process that you can continuously do. And with that, it's the conclusion of the lecture. Like we said at the beginning, I know there was a lot of material today, and it sounds like a lot of discussion in the chat. I think the biggest take-home message is we're trying to introduce you to the material today, and then all of my wonderful colleagues and co-speakers starting tomorrow and then through all the subsequent weeks are going to talk about these topics over and over again using their own perspective and their own site-specific, orientations. So at the end of the whole process, we're confident you're going to have a high comfort level with plan checking and plan quality reviews, even if you're not quite there, after today. And thanks again to Lindsey and the team at RCC. I really appreciate the opportunity to have been able to speak. And Lindsey, if you think we have time for questions or people want to stick around, I'm happy to stick around.
Yeah. Thank you, Sean. That you articulated everything so nicely, and I hope everyone really was able to get a lot out of this session today. I think we were able, in the interest of time, to address most questions in the chat. If people have time to stick around for one or two, I would just ask you, Sean. Someone asked, what is the perfect dose gradient for SRS? This one I'll just mention, there will be a session tomorrow on SRS SBRT. So I just wanted to put a plug in for that session where our colleagues, Muhan and Justin, will be discussing a lot about dose distributions for SRS, and they will be going into how we assess plan quality using dose gradients in tomorrow's session. So we'll leave that one for tomorrow. And then, Sean, someone did ask that they read a paper about using Play-Doh for bolus and what your thoughts were on that. Thought that was an interesting question.
Yeah, interesting question. So Play-Doh. Play-Doh is what? Basically flour and water mostly?
Pretty much.
I guess. Yeah.
Salt.
I'm not sure. I guess I don't know exactly. I guess it's probably similar to water equivalent. I'm not sure about the flour. I guess I would say if it's water equivalent, which you can evaluate by all right, maybe I should step back and try it like this. For any new material that you intend on using on a patient, even a mobilization device, anything that you're going to be using as part of your beam transmission, it's a good idea to come to a good understanding of the radiological qualities of that material. So if you wanted to use Play-Doh as bolus, I would recommend, doing some transmission measurements of that bolus so that you understand, how much thickness you would need. Also doing some evaluation of how that bolus would stand up over the course of treatments in terms of keeping its shape and not crumbling, drying out, other things like that. So I think maybe I would answer that. I don't know about Play-Doh specifically, but I think I would say more generally for anything you're going to use on a patient, you need to understand its physical properties, especially throughout, the duration of treatment and its radiological properties. I don't know if you have anything to add to that, Lindsey.
That's exactly what I would say. And anytime we're going to be using something new in the clinic, we will perform a scan with it, try to understand what the material properties are, the density. Also, when considering bolus, one nice thing with something like Play-Doh is you can avoid air gaps, so how it will have benefit clinically. So just approaching everything with that kind of critical thought process and understanding how it might impact the patient will go a long way.